We'll sort of look at some crossroads of old and new. And in terms of where we're at, it's amazing to think we're well into the third decade here of our experience. It goes way back, of course, in terms of when the virus probably made the leap to humans and so forth. But my, oh my, the progress we've made. And I really think the last 20 years have been a gradient of success, and I'll explain what I mean by that on this slide. When we think about how long does someone have to live who has HIV, it's a question that still comes up quite a bit. The patients ask, the families ask, and we get queries, for example, elective surgery. How long will this person, do they really need? And these kinds of data in the era of highly active antiretroviral therapy since the mid-90s have really just continued to grow and get better and better. So this particular study I like because it looks at different eras since the mid-90s. In other words, where we started in the mid-90s was really important, but we've only gotten better since. And the gradient of success continues to grow. So add 20 to this number, and that in this particular cohort is the expected lifespan of someone with HIV on therapy. So for all intents and purposes, it's basically the same as HIV uninfected individuals. Well, we're here, 2015. I've showed this slide for a few years, and it always surprised people that by the time we get to 2015, over half of folks living in our country with HIV and AIDS will be over the age of 50, and that, sure enough, we're here, and that's true. And so it's amazing the ability to live long. It also brings up transmission issues in those over 50, which we can touch on a little bit as well. So there's some things that are old, and I'm not going to spend time on. How to prevent opportunistic infections is exceedingly important, but it hasn't changed at all since the last time you would have heard anything about HIV. In the very end of my slides, I have several slides on OI prophylaxis, vaccines, and I have the workup for someone newly diagnosed. I thought I wouldn't spend time here doing that, but I can answer questions this weekend if you have them. And by the way, thanks so much for the outstanding questions about vaccines. And one of the great things about this format is well, I'm here all weekend, so whatever questions you have, please ask them and we'll try to get you answers. The need to test and refer is every bit as important as it has been. Our prevention efforts haven't been what we want. We're still stuck at the same number of new infections each year in the US, about 50 to 55,000, and that's a problem. What's new are a tremendous evolution of medications. In a different light than the incredible hepatitis C medications we can't cure, we can suppress quite a bit, and patients are living full lives. What we spend the most time on, and when students and residents come to my clinic and they work, I think they expect to see patients with cryptococcal meningitis and toxoplasma. I can't tell you the last time I treated someone with toxoplasma and AIDS. It's been forever ago, but every week I got 2 or 3 people with osteoporosis. I get someone discharged from the hospital with a stent, and I learned that someone just got diagnosed with lung cancer or rectal cancer or something, and they need chemotherapy. So this is really what we spend our time, even in the setting, especially in the setting of successfully treated HIV. Renal and bone health concerns are huge, and they're driven by a wonderful medicine called tenofovir, which we're going to talk a little bit about today. Prevention efforts have taken a step up, with the most important being treatment as prevention. I'll show you some data, and also something that you might have already gotten questions on, PrEP, pre-exposure prophylaxis. We'll talk about that. Here's a listing of some important guideline updates. The best resource for HIV guidelines is right here, aidsinfo.nih.gov, adult, adolescent, perinatal, pediatric, post-exposure, occupational, non-occupational, you name it, you'll find it there. Opportunistic infection prevention and treatment. It's simply the best resource. What is nice is that they finally updated the PEP guidelines. Boy, it took them forever. And those of you in occupational health, urgent care, ER, if you have some responsibility about being a part of your institution's response to HIV exposures, it's important to take a look at the relatively new guidance. PrEP, we'll talk about, and the guidelines for actually managing HIV are updated continually, much like what Dr. Sanyal shared about hepatitis C. We're also going to talk about new testing. So what should all clinicians know about HIV testing? Well, the testing recommendations are here, CDC's and the Preventive Services Task Force. And the sea change, of course, was 2006, where the CDC said Risk-based testing, just asking about risk factors, has failed. We got to do something else. They introduced the idea of testing virtually everybody at least one time in their life. So the formal recommendations are here. 13 to 64, a routine screen, unless the prevalence is so low, and I'm not sure how you're supposed to know that. All pregnant women, starting TB meds, STD clinics, and then if you're high risk, and they define high risk behaviors, you want to get tested more often. The Preventive Services Task Force, both grade A recommendations for folks in a similar fashion here, 15 to 65, or even older, even younger if they're at risk, all pregnant women, so another important item here, and then some suggestions about rescreening. So the two different agencies, if you will, are in concert in terms of screening a broad array of individuals, considering it part of routine health care, integrating it into the exact kind of screening that everybody in the audience here is so good at in terms of colonoscopies and PAPs and mammograms and so forth, considering it part of routine care. Opt-out testing is one of the areas I want to focus on. So this is a situation from a few years ago from University of Massachusetts. An academic clinician treated a woman for HIV for 9 years. The only problem was she didn't have HIV. And so when the test was subsequently obtained and she was negative, it led to this. And one of my very practical things I want to share, and I just simply don't let my guard down. If it's someone I'm meeting new in a clinic and they come from another system, if it's someone who's newly diagnosed and I don't have those records, if it's someone visiting their family for Christmas and New Year's and they get something and they're in the ER, just always get an HIV test. Believe the history, act on the history, that's great, but verify with a test for someone new to your healthcare system or new to your clinical practice. We've seen plenty of cases where, unfortunately, the HIV serologies were misinterpreted or other reasons as well. This gets at the heart of the opt-out. So this is an individual who had pancytopenia, and her doc said, well, there's a differential, and one of the things we ought to consider is HIV, very potent bone marrow suppressing virus. He offered the HIV test. She declined it. She declined it on numerous occasions. A clinic staff member decided to order it, and lo and behold, she's HIV positive. Well, the good news is we can treat HIV and help you with your cytopenias. The bad news is she didn't want the test ordered, so she sued the clinic. So opt-out testing is that. The individuals should be allowed to opt out and clearly documented that they don't want it, or conversely, clearly document and you note that they agree to get the HIV test. So we don't want to sneak it in with the fasting lipid panel, when we do it. We want to get it in this kind of true opt-out sense. This is embarrassing. This is my hospital. We had 2 episodes of inappropriate disclosure, and it made the news. This is our local newspaper. It's a university hospital. It's a big academic medical center. And what happened was busy docs, some of them trainees, were rounding and so forth, talking to patients, getting, in that just mode of going from room to room, and there was a room full of people, and it happened twice within about a year and a half of each other that disclosures were made with people in the room that shouldn't have heard the news. So be real careful in crowded rooms. I've tried hard to check my own practice. You get in that busy, you're going from room to room, it's a busy day, and you're doing your hospital work or rounding or you're in clinic or what have you, and just take a moment and we gotta all be careful about our practices. So I wanted to share that with you. Here's a case for you. So this is a young woman, and it's in early May. And I'll never forget this because it was a Tuesday afternoon, I was getting ready to start my clinic, and my beeper went off, and the paging operator said, Dr. Urban, I have a call for you from Hollywood, California. And I thought, man, this is it. This is my big break. So I started taking off my lab coat, but they said, no, it's an ER doc. All right. So it was an ER doc from Hollywood, California, not maybe other folks I would have liked instead, but a very nice ER doc. And this individual, who's the wife of one of my patients, was in his ER, and she had been out there, showed up with a week of fever and fatigue and sore throat and muscle aches and had a rash. And a rapid test in the ER was non-reactive. And so the ER doc said, explained the story and said, he goes, I know what you're thinking. He goes, the rapid test is negative, so the good news is she doesn't have HIV. And I said, well, what do you think she has? And he said, well, I think she probably has influenza. Okay, so take a minute, critique the ER doc's assessment. Do you agree or disagree? Rapid test negative, those symptoms, what do you think? I like it. Why do you disagree? What might be going on? False negative. Not enough time for the antibodies to generate to make that rapid antibody test, the rapid serology we're all used to, turn positive. Acute HIV is still highly relevant. It's a very, very hard diagnosis to make because it's so darn nonspecific. It's transient, it's the acute illness that happens a few weeks after getting exposed, and it's a flu or mono-like illness. It's every patient we all have on our schedules in January and February, and everybody, I'll show you the symptoms, but there's nothing that can really help us too much. What it's characterized by is it's the time point of the illness that has the highest amount of virus in that individual's blood that they'll ever have. It's extremely high viremia. As we'll look at in other contexts, it's a dose-response curve in terms of transmission. Higher the levels of viremia, the higher the levels of transmission. So it's a tremendously important public health transmission risk. It's estimated that over half of the transmission that occurs with HIV occurs in individuals who just got it themselves. It also is characterized by the presence of an antigen called a P24 antigen, which we all probably learned about somewhere along the way, but it's made a resurgence in popularity. And it's also characterized by indeterminate or negative traditional antibody testing. Here are the symptoms: fever, fatigue, sore throat, I feel terrible. It's every patient on our panel in January and February and so forth, in December. Here are some clues: a rash, people with the flu, folks with mono who haven't received amoxicillin shouldn't have a rash. Over half of folks with acute retroviral syndrome will have a rash. There's nothing specific about it. It's a flat red rash, typically on the trunk and chest. So again, there's nothing highly specific about it, but it might be a clue. Aseptic meningitis in a quarter of the cases, so turn that around. If you're a hospitalist, if you work in ERs or what have you, if you have someone with aseptic meningitis, acute HIV has to be on your differential. Oral ulcers and genital ulcers, far lower percent, but if you find them, again, they can help separate out the flu from this. This was a study in a Southeast US healthcare system, a few years old now, but it just shows how challenging this diagnosis is. Basically, folks who came to ERs and urgent cares, from presentation to diagnosis, over a month, 5 were still undiagnosed. Half of them required 3 separate visits before acute HIV was diagnosed. I wish there was something I could say to you or any group that would say, that's the aha thing to make you get that HIV test in this context, but the answer is I can't. There isn't anything. You have to think of it, have it on your differential, and order the tests when you think of it, and also identify typically some risk factors that is probably the reason why you thought of it in the first place. It's very challenging. What happens to that individual is striking in the early phases of infection. So on your left is a biopsy of a Peyer's patch, a terminal ileum node biopsy. The gold stain stains for CD4 cells. So in the HIV uninfected individual, and true for all of us, this GI tract is the largest repository of CD4 cells, just loaded with CD4 cells. Over here is what happens just 3 weeks after acquiring HIV. So what happens is the largest repository of CD4 cells gets decimated early, within a few weeks of getting infected. And this is important because ultimately what it does is it distorts the architecture of the GI tract. We get a lot of concerns and well-documented translocation of not E. coli getting into the blood, but the bacterial products and immune activation that takes place has been well demonstrated. The architectural distortion that takes place across the GI tract leads to an ongoing, vigorous immune activation at very very discrete levels in our body, but very high immune activation. And we think that this immune activation over time is what plays into some of the very high risk we're seeing of things like other inflammatory conditions, like cardiovascular disease or cancer risk, for example. But I just wanted to point out, things happen quickly once you get infected. And again, at 3 weeks, many folks are not that symptomatic, or their symptoms are mild, and again, it's a flu or mono-like illness. But a lot of significance here, and it's a real important time point if acute HIV is diagnosed to get that person referred and into care. Now, how do we diagnose it? First off is thinking of the possibility, recognizing the syndrome, and then we have to look directly for the virus because our traditional antibody tests are going to be negative or they're going to be indeterminate during this particular time point. So the ways to look directly for the virus are two. One is to get a P24 antigen, and the other is to get a PCR for HIV RNA, a viral load. Okay? So this is historically how we've gone about trying to diagnose acute HIV. Times have changed. I'm sure all of your institutions by now have ushered in the 4th generation HIV tests. And specifically for the reasons and cases I've just gone over with you is why 4th generation tests have come along. This particular figure here basically shows us when someone gets infected here, what happens over the time course. Well, the 1st generation tests that came out in the 80s wouldn't turn positive for a couple months. And we all know historically, after a discrete exposure, we've historically gone out about 6 months afterwards to try to capture the seroconversion that can take a long time. As the testing has gotten better, the generation, 2nd generation here, 3rd generation here, the window period, right, the time point of the antibodies being negative has slowly moved toward detecting earlier the antibody response. So the antibody testing we've had in our clinics and hospitals now for a good number of years preceding the 4th generation, on average would turn positive about 21 to 28 days, so 3 to 4 weeks after someone got infected. So that window period on average was 3 to 4 weeks. 95% of people would turn positive by about 8 weeks, but 5% would go out to 6 months. And that's the rationale for following someone out that long after a needle stick or after a sexual exposure or what have you. The 4th generation tests are right here, and they've pushed this to about 15 days. And how did they do that? They incorporate a P24 antigen. They incorporate the antigen right here called P24, which is that transient early viral antigen. So this is the viral load, the HIV RNA, which is a tremendously high burden of virus during acute HIV. Here's the transient antigen called the P24, and here's the antibody that takes its time and then finally shows up. So 4th generation tests are here, and what they are combination antibody-antigen tests. ELISAs and Western blots are gone. And what this does is it combines antibody testing for HIV-1, which is the HIV we're all familiar with antibody testing for HIV-2, which is a much less common virus globally. It's a virus most found in Central West Africa, Southeast Asia, to some extent Portugal. It's made its way out, but it's a much less commonly encountered HIV version. But on a global scale, it's present. In the United States, we've been testing for it since the late 80s, so it's not like we haven't been looking for it. But the number of cases have actually been very low. But all of our algorithms have had HIV-2 diagnostic capabilities in them, and we continue to do that. But what the new 4th generation tests do is they put an antigen along with these guys, so it's a built-in method to diagnose acute HIV, which is pretty neat. Faster turnaround time, we use this now for screening, and let's say there's still a reactive test, like let's say my patient's wife in that ER, that was a few years ago, but if we had that rapid test would have come back positive, this is now what we would use to follow up or confirm a positive rapid test, okay? So 4th generation. I don't like this, but I have to go through it with you because it sort of explains the crux of all this. So ELISA and Western blot are gone, and this is how it works. The first step in the 4th generation test is this combination HIV antigen antibody assay. If it's negative, the testing stops. If it's positive, you don't know which of the 3 components that made it turn positive. Was it antibodies to HIV-1, which would be screening for established HIV? Was it antibody to HIV-2, or was it the P24 antigen? So then, the next step is to figure that out, and that's called an antibody differentiation assay. So if the combo is positive, it moves on to the 2nd step. And then there's several possibilities. It discretely checks HIV-1 versus HIV-2. So if HIV-1 is positive and 2 is negative, there you go. We've detected HIV-1 antibodies And the combination of this being positive here and this being positive here means someone has established HIV. Let's say the HIV 1 is negative, but the 2 is positive. That's how we make the diagnosis. Positive here, someone has HIV 2. Again, that's a very rare event in the United States, but it does happen occasionally. Sometimes the test can't figure it out, and I've had patients like this, where both are positive, and it just tells you that, well, we've detected antibodies, we can't separate them. And then sometimes in this algorithm, the HIV antibody part for both 1 and 2 will be negative. So again, up here, our combo was positive, this is negative, so then the test says, maybe it was that P24 that caused the initial screen, the first step, to be positive. And so it does something called a nucleic acid test. And indeed, if that's positive, that means the signal up here was that P24, which means you've diagnosed acute HIV, okay? If that comes back negative, that means your problem up here, or your positive up here, could have been a false positive, or there's some other explanations too. So ELISA Western blot is gone. Breaks my heart to some extent. And this flow is what is out in a wide array of commercial labs. I would bet that all your medical centers have 4th generation tests now. My experience, this is my experience, not the literature, because the literature isn't real replete yet. We're seeing a lot of false positives, much more so than our traditional algorithm. And guess where we're seeing them? We're seeing them in pregnant women. When I compare notes of the questions I get versus our pediatric HIV specialists who help do the liaison with pregnant women and trying to decrease the risk of mother to child, we are seeing a significant rise in false positives. So just be aware of that. And if that testing comes back positive, obviously that's a very concerning thing, because if it's truly a positive, you want to get the pregnant women on antiretrovirals to decrease mother-to-child transmission. But what you want to do is call your local HIV specialist to try to help sort it out. So anecdotally, and I would emphasize anecdotally, we're seeing more false positives. Some of these sequences, remember the step 1 and then the step 2, we have a well-known healthcare system in our town, which many of you, all of you probably would recognize, that requires the patient to go back and get the second step redrawn again. In other words, they can't do that whole algorithm that I showed you. They can't do all of this on one tube of blood. You got to get this, and then it says, oh, it's positive. Tell the patient to go back and get it redrawn. That is a Stone Age thing. That's awful. But the fine print actually is where you learn that that's what you have to do. And I've seen that be very confusing. We don't have recommendations for serial testing. So I've already mentioned with our 3rd generation tests, if I get a needle stick today, you're going to test me today and say, Dr. Urban, you're negative, but that test doesn't tell us anything about today's needle stick. It just says you are negative at baseline. We're going to follow you for some period of time to see if you seroconvert. And maybe you'll put me on PEP or whatever. But traditionally, we've gone out 6 months. With these new tests, we don't know how long to go out. They don't tell us in any of the guidance. So I'm still going out 6 months personally. There's a hint in the post-exposure prophylaxis guidelines that are a couple years old. They hint at maybe we could cut it off at 4 months, but I've seen no data and no recommendations that really supports that. So my practice and what I share with our primary care colleagues in my community is go out to 6 months until we learn otherwise. This is a patient of mine, and those of you who've been in practice a while or trained in the 80s and 90s will certainly recognize this. She lives up in the central part of Wisconsin near some fabulous medical centers in the central part of the state. She was hospitalized there with tremendous weight loss. She was down to 88 pounds. She had newly diagnosed psoriasis that was recalcitrant, couldn't be treated, and she got hospitalized for recurrent MRSA facial cellulitis. So she was hospitalized once at a terrific medical center in central Wisconsin. She came down to our university hospital, got hospitalized for one of these bouts, got discharged. It was the 3rd hospitalization that led to someone considering HIV in her case. Now just take a step back, especially if you trained or were practicing in the 80s and 90s. Tremendous weight loss. Remember psoriasis? This was one of the first skin conditions that were recognized in the AIDS era. Recalcitrant, impossible to treat psoriasis and a recurrent infection. What a perfect recipe for HIV. 2 good medical centers, 3 admissions, it wasn't considered. So the red flag list is alive and well, and I just share this, and I want to highlight a couple. Recurrent pneumonia, aspiration, of course, a dime a dozen, right? Immunoglobulin deficiency is pretty unusual, worth thinking about, but don't forget about HIV. Any unexplained weight loss symptoms, and I'll also throw in unexplained cytopenias. So these are things we want to still think, could this be HIV? Any STD, any Hep B, any Hep C, you have to reflexively order an HIV test. TB leads the list, but they're all on the list. So the update in testing, someone new to your practice, your hospitalist, you're treating them for pneumonia, and they say they're HIV, great. Do what you need to do, but get an HIV test. Same with clinical outpatient care. Opt-out testing, document permission, be careful in crowded rooms. Acute HIV is a huge topic right now. We believe it's valuable to treat as early as we can when someone's acutely infected. That's the need to test and refer. And then don't forget about the red flags and some caveats and advantages about these 4th generation tests. So what about the meds? You heard about awesome meds today, and I'm going to pinpoint a couple of areas for HIV meds today for you. As Jan hinted at, I love talking about HIV. I've been doing it a long time, and this is what usually people say, man, he talked too much about those meds. I'm never going to prescribe them. Or some years go by, and, well, he didn't talk enough about those meds. Those are neat meds. So, you can't win. But this time, we got to talk about some drugs. Why? Co-management. A lot of good issues in co-management. Viral load predicts transmission risk, whether you're pregnant and infected, whether you're heterosexual, MSM, what have you. It's a dose-response curve. The higher the viral load, the greater the risk of transmission. The lower the viral load, the lower the risk. The risk is not zero, but it's a clear dose-response curve, leading to an incredible intervention of treatment is prevention. So in this study published a few years ago, daily antiretroviral therapy in the partner who is HIV positive, this is a serodiscordant couple, led to a 96% reduction in HIV acquisition in the HIV negative partner. That's huge. By far, it's the most successful prevention intervention that we've ever had. So treating HIV is very, very important for limiting transmission to someone who doesn't have it. The antiretrovirals have evolved, and we have 6 classes, and I'll just show you briefly how they work. Here's the virus coming in. We can block viral entry in 2 different ways, 2 different compounds, a fusion inhibitor, and we can block one of the co-receptors called the CCR5 receptor. Over here are drugs you're familiar with, the nucleoside reverse transcriptase inhibitors and the non-nucleoside. So we have 2 ways of inhibiting reverse transcriptase. We have an exciting class of drugs that, quite frankly, has eclipsed many of the other older drugs, and these are called integrase inhibitors. Viral integrase takes our chromosome, splits it apart, it takes the DNA copy of the virus's RNA, puts it in, and seals it back up. And we have 3 drugs now that inhibit one of 3 steps in that process. Transcription, translation, big polyprotein sheets get made, and viral protease cleaves the polyproteins into small subunits that then get packaged and assembled at the cell membrane, and the virus goes off on its merry way. So there's 6 classes of antiretrovirals. This slide, I love it. I hope my font gets smaller over the years. It means we have more options. And these 6 classes I'm not going to belabor. I'm going to focus actually on something over here, fixed dose combinations. So some of you remember where we had a lot of consternation about when to start therapy. Well, certain viral loads, we're going to do this. We're going to wait for a CD4 count to drop to a certain level because the meds are tough to take, full of toxicity. All that's gone out the window. Every international guideline now over here support the idea, and the punchline is easy. Anybody at any CD4 count should be started on antiretrovirals. Resource rich, resource poor, all the guidelines are unanimous now at saying, irrespective of symptoms, irrespective of AIDS, irrespective of CD4 count, viral load doesn't even enter into the equation. We treat. How and when and what do we do? Everyone when they're ready. What does that mean? Well, if you don't have a roof over your head, and if you're struggling with mental illness that's untreated and substance abuse that's active, the last thing we want to do is launch into HIV meds, because remember, if we do that and they can't adhere, we're going to quickly and rapidly select out drug resistance. So we still want to optimize the barriers to adherence. And what do we use? We do get baseline resistance testing, standard of care. About 16% of newly infected individuals will have transmitted drug resistance. And what do we use for initial regimens? The details aren't important, but the highlight is 5 of the 6 regimens that the DHHS say these are our initial regimens, they're with this integrase inhibitor group. The integrase inhibitors have completely taken over the lion's share of initial therapy in HIV. Why? Because they're highly effective, they're remarkably well tolerated, and they come in a variety of strategies that make it a lot easier for our patients to take HIV meds. Interestingly, despite all this, despite the simplification, nothing simple about HIV care, but it's gotten better, the drugs have gotten better over time, people still change their combinations. Now you might say, well, it's probably because of resistance. In the old days it was. This is recent from a group in Italy who looked at their patients, and believe it or not, the number one reason why people changed their HIV meds was to make it more simple. It wasn't resistance. Resistance is right here at 2%. It was actually the lowest percent reason for changing HIV meds, which is remarkable. People want to have a simpler regimen, and they want to have a less toxic regimen in general. That's the driving force behind a lot of what we're seeing with antiretrovirals. I could show you a bunch of these, but I won't. The bottom line is any contemporary HIV regimen that we use now has about a 90% success rate in clinical trials at suppressing the virus. It's just extraordinary. But this is real world right here, not clinical trials. This kind of care cascade, which is relevant for HIV, hepatitis C has one, other infections, basically says, here's everybody that's infected. We've only diagnosed this many. These are the ones who've been diagnosed linked to care. These are the ones retained in care. These folks need therapy, these folks are on therapy, and these folks are undetectable, right? So all of this really bespeaks to the hot topic of linkage to care, making the diagnosis, getting someone established and keeping them into care. So the real world is about 20% of folks in the US have undetectable viral loads. The clinical trials say it ought to be 90. Obviously, there's a big difference between the world of clinical trials and real life. So this is an important slide and topics for another day, but it really talks about one of the hottest areas right now, which is linkage to care. These articles just came out the December 15th issue of one of our infectious disease journals from New York here, and basically, those of you who've been in practice for a while have seen this pendulum. You know, HIV management's a specialist disease. They ought to be, specialists. Wait, let's make it a primary care disease. Well, maybe not. Resistance, complexity, it's a specialist disease. Well, much like, in fact, exactly like the discussion earlier today about Hep C, there's very much a large driving force to want to get HIV care more in the hands of primary care. This push is especially prominent in the community health center population. And basically, it's for the same reason. Very few people are going into HIV care, and who's doing it or retiring, and there's more HIV than ever. We need people to do this work. So this study looked at volume, and it broke down low volume providers treating less than 20 patients versus those treating more than 20, a rather arbitrary number, but to give you an idea. And basically, they looked at a variety of quality measures. Several of these I would disagree with, but they actually, as to their importance, but they looked at 2009, so a few years ago. But the one that stands out is viral load suppression. The low volume providers versus the high volume, there was a major difference between the two. And a lot of it has to do with support structure. The clinic I work in is loaded with pharmacists and social workers and linkage to care specialists and all the support mental health providers, and we don't always have that in our clinics, especially at close hands. So, there's a push to integrate into primary care the main management, and there's a push to keep HIV specialists around. And the thing of it is, to be an HIV expert or specialist or whatever word is, you sure don't have to be an infectious disease doc. In fact, the head of our program is a general internist. The head before him is a rheumatologist. Some of the most preeminent figures in HIV research and care are not infectious disease. I know a lot of ID docs who really have very little knowledge about HIV. So the point is, it's how many patients you see and not your background training. Here's a lot of co-management areas that come up, and it's impressive over the years how this model has evolved. To me, it's just flat out fun. I love co-managing our patients with local primary care providers. I love we take care of patients solely in our clinic as well, but the co-management model is important. I highlight diabetes, hypertension. Look, we just spent 2 hours talking about these today. Osteoporosis, osteopenia are huge topics in our patient population, and I look for help from our primary care colleagues a ton for the best way to manage these early and very severe bone demineralization issues. But it's important. Who's ordering the screening colonoscopy? Who's ordering the pap smears? Who's doing the vaccines? So co-management has its sort of classic concerns you just have to sort out. Let me have you take a look at this case. He's a 34-year-old who's coming to a primary care office. He's got well-controlled HIV. He's got seasonal allergies and allergic rhinitis. He uses loratadine as needed. He takes Stribild for his HIV. So what would you recommend for enhancing or treating his allergic rhinitis and seasonal allergies? So would you recommend fluticasone nasal? Fluticasone now it's over the counter. Beclomethasone nasal, change him to fexofenadine, or a neti pot. So a guy with seasonal allergies, allergic rhinitis, probably seasonal driven, what would you recommend for best management of those extremely common conditions? Okay, good. All right. Yeah, and I'm glad we're doing this. The answer is C. The answer is actually C. So let's talk about this. I actually think this is the most important of all the, we've had such a wonderful discussion already about the concerns about drug interactions. Dr. Steino brought it up, Jan brought it up with pravastatin. Our single tablet regimens now, there's 5 of them. This is what people start therapy on. 3 or 4 medicines in one pill. There's a bunch of them, and all of these are just terrifically potent combinations. Fixed dose combinations, not unique to HIV, we've already heard of them, but there's 5 different ways of having all your meds in one pill. And then there's different components over here. So these over here might have 2 or 3 medicines, but they're not a one-stop shop. They're going to be combined with other medicines. So the bottom line is we have a lot of components or single tablet regimens in HIV. But here's the problem. Just about everybody's going to be on one of these, and it's going to have 2, 3, or 4 medicines. No one will come to your clinic and say, yes, Dr. Smith, I'm on the fixed dose combination of tenofovir, gemcitabine, cobicistat, and elvitegravir. They're going to say, if they know what they're on, they're going to say, I'm on Stribild. So you have to deconstruct these things. Everybody calls them by their trade name. Creatinine clearance is critical, and beware of the hidden PK boosters. I guarantee you, whatever EHR you use, it will not save you. It will not take care of the surveillance for drug-drug interactions that you want it to or may rely on having for you. So let's take Stribild. That's what this gentleman is on who's coming to our office for allergic rhinitis. It has tenofovir, which is our one true nephrotoxin. It can cause acute kidney injury, Fanconi syndrome. Tenofovir and imtricitabine are nucleoside analogs. Both of these need to be adjusted for renal impairment. So if the creatinine clearance gets low enough, this Stribild needs to be not given. It needs to be discontinued, and the individual components given with the appropriate renal adjustment. Cobicistat has no HIV activity, but it's a very potent P450 inhibitor. Huge drug interactions. Elvitegravir is an integrase inhibitor that's boosted by this cobicistat. That's why it's around, and that's why they're paired. Interestingly, that has some unique, quirky interactions of its own. There's a medicine that you will hear about that's coming. It's already been FDA approved in one fixed dose combination, and 2016 will usher in a whole bunch. So that's why I want to mention it, and it's easy to remember because it's called TAF. Everybody calls it TAF. It's the prodrug of tenofovir, which is an incredibly widely used drug in many things you probably have heard of already, in the Stribild and Truvada. It's the PrEP drug. It's the post-exposure drug. We use tenofovir like water. The problem is kidney toxicity and bone demineralization, known in the pre-marketing phase of the drug, but exceedingly important. The most common conversation I have in my HIV clinic, 2 to 3 times a week, every week, has to do with hypophosphatemia, proteinuria, and your DEXA shows osteopenia or osteoporosis. And most people are on tenofovir, so it's a huge issue. What's happened is Gilead has come out with this prodrug, and basically it gets much higher concentrations in the cell where it's converted to the active form, much lower concentrations in the plasma. And what this translates to is less kidney and less bone toxicity. So the point of me mentioning this is that you're going to have a lot of even newer and differently named fixed dose combinations coming out in 2016, including the one that you might have people on PrEP for. So tenofovir, alafenamide, don't worry about that. TAF will hit the market, and it's already here. The biggest thing I can share with you about HIV, in addition to testing, is drug interactions. So drug interactions can be in terms of blocking the absorption or the well-being of the HIV drugs. Historically, these have been proton pump inhibitors, H2 blockers, and antacids, and the bottom line is please check on them because they can be very relevant, not for all, but for certain meds. But this is really what we want to focus on. Toxicities can be very dangerous. Jan pointed out statins. And what it has to do with is PK boosting with ritonavir, which is a protease inhibitor, and this cobikistat, which is a medicine that was invented, developed specifically to boost other meds. It has no HIV activity, but it is part and parcel with several of those fixed dose combinations. So it's a hidden booster. It's highly relevant in terms of drug interactions for a whole variety of HIV meds. Keep it simple, always look them up. And again, I can't emphasize enough, your EHR will not save you on this. So this guy on Stribuild, if we take it apart, the cobikistat that's buried in there with its P450 inhibition raises a big concern about corticosteroids. Here's just 3 articles I picked, and there's many more. Cushing's, followed by Addison's in HIV folks on protease inhibitors getting inhaled corticosteroids. Here's a literature review of the reported cases in this study, about 80 of them, I think, in the literature. And then here's local corticosteroid injection with high frequency of dysfunction on protease inhibitor therapy. In my clinic, we've seen 6 folks get into trouble with inhaled, intranasal, or injected corticosteroids. And even, and this is always surprising to people, but yes, even the intranasal fluticasone can get you into trouble. Fluticasone is potent, and it's the one heavily dependent on P450-3A4. So it's the biggest problem because it's such a good steroid. So nasal and inhaled steroid management options for patient on protease inhibitors, beclomethasone has much less P450 metabolism, so that's the go-to instead of fluticasone. One of our concerns is that since fluticasone is over the counter, people can go out and get it, obviously. Sometimes we'll even have to change the HIV regimen to a non-PI containing one. For example, someone heavily dependent on fluticasone for asthma or COPD or what have you. For patients on that cobikistat medicine, we want to find an alternative to fluticasone, and beclomethasone is probably the best choice. Injectable steroids, this is currently my biggest bugaboo because we don't know many times when our patients are going to get injected knees or back or what have you. So the exact same concept applies. If anyone is getting anything injected and they're on HIV meds, please call the HIV doc, have your pharmacist check. It's a huge issue. So in our 6 cases, the first one presented with a hyperosmotic, hyperglycemic, not coma, but blood sugars of 900. The last 5 were Cushing's that turned into Addison's. So it's a big deal. I'll actually change their antiretrovirals a week before their knee injection or their back injection. It's that big a deal if there's an interaction. So just to be clear, not every HIV medicine has this interaction, but just check them all out, and then you're going to be in good standing. To follow up on Jan's comments, in HIV, even if the calculator says in their background, don't start with these doses until you know it's safe. If you started atorvastatin 40 or 80 in one of our patients, and again, they're on the right or wrong combination of HIV meds in this case, they'll have tremendous statin toxicity. So check it out, start low and titrate up, even if they're in this category, and that's really the approach I use and what I'd recommend. On the inpatient side, medication errors are common. It's really forgetting parts of the regimen, having incorrect doses, drug interactions, or not adjusting for renal impairment. So these fixed dose combinations, you got to break them apart and analyze what might need to be changed. For those of you who do hospital medicine, when someone's admitted, double check all those things and don't force them down NG tubes. And always stop them if you think someone's coming in with a hypersensitivity or they got a severe GI illness or liver toxicity, transaminitis, what have you. Always stop them. Remember, it's an all or none phenomenon. Don't give a partial regimen. Let's see, how are we doing here, Kathy? Oh, straight up 1 o'clock, so I better wrap it up. Give me a couple slides on PrEP, because it's such a hot issue. PrEP is pre-exposure prophylaxis. There's guidelines that are current, and they're pretty straightforward, actually. What it is using antiretrovirals to prevent getting HIV for someone who's at risk and HIV negative. Truvada, tenofovir, FTC is the only FDA-approved antiretroviral for this. The studies have been done, and the FDA has approved it for this use. Efficacy correlates with taking it, which is no surprise. This is a table from the guidelines, and the only thing I wanted to use this for was to highlight this isn't just for MSM. So here's men who have sex with men, but here's heterosexual men and women. Here's injection drug use. So it's not just MSM where it tends to get most of the press, but there's many other situations where PrEP can be considered. You have to test very often, every 3 months with HIV tests, and then there's some toxicity monitoring and STD screening, but actually it's a pretty straightforward recipe of what to do. Here's just a checklist which can be given to the patients. Here's the news. A daily pill, this made around World AIDS Day, and you can see about 1% who could benefit from it are actually on it, according to the CDC. I mention this just because there's a big push right now to integrate PrEP into practice, and patients are going to hear this and probably bring it up more often. This was just published a week or two ago, and this is on-demand PrEP, which I just want to emphasize is not recommended in the guidelines, but what it is taking pills right around the sexual event, and then it showed a significant decrease in the risk of acquiring HIV. So not taking it daily, which is what the current PrEP is, daily, right? This is taking a few pills before and after the sexual event, event-driven PrEP, and it actually had a very significant decrease in the risk of acquiring HIV. Will this be integrated at some point? We'll have to see. Into the guidelines, we'll have to see. What kind of cases are out there? There's a bunch of them. Don't forget about the adolescents. This is the worst part of HIV epidemiology, I think. The risk behavior is off the scale. We're seeing tremendously high cases in certain subgroups, again, for a different talk. Some of the questions and comorbidities like we've talked about. Here's some things to refer. And HIV is always in the news. This is the largest number of cases in Europe. This was the Indiana outbreak from earlier this year. And of course, how can you not talk about Charlie Sheen? So this was from Forbes. I think I read some lips out there when I said that. I know what you mean. Here are 5 things that Forbes listed. We can do Q&A later or when we get to it on Sunday about it, but it brings up some interesting issues that are hot. We do a lot of family planning in our clinic. Vaccines I can talk about Sunday if you'd like. PrEP is a huge issue. The epidemic is growing, and if you have access to care and you're on these amazing meds and you stay in care, you're going to do real well.